You have to start the webinar, Robert.
I've already started. There's just participants coming up.
Thank you.
We'll just wait. There's just increasing number of participants coming in.
Okay, so do you want to introduce the staff, Roberti, and then I say hello, and what do you want to do?
I think I'll just welcome them and then say a prayer and then pass it on to you.
Okay, but we might have to say that we have issues with getting our speaker on.
Yeah. What? There's only like 13 participants joining in.
Yeah, so we might just wait a bit.
Yeah,
Until
we'll just wait. There's about 69 registered, so
okay.
We'll just wait until
I think we get a bit more numbers.
Yeah.
Yeah.
Oh, hi everyone. I'm just getting Silipa on because she's having difficulties logging in. So, but greetings everyone in the Pacific, and I'll just be coming out of the video so that we can get Silipa organized. You might have to keep talking. Roberti, say hi to everybody.
Pacific greetings to all you participants. As you start to access, please just be patient with us. We just have a few issues trying to access our speaker from Australia, and Kara's helping her. We got Dr. Ling Tang with us, our facilitator, and also Michael just joining us as well. Just welcome everybody again. Thank you, Shan Chivan. Sorry, we're still trying to get connection to our speaker from Australia. Please just be patient with us. I was introducing you the Dr. Ling Tang, our facilitator, and also Michael, our speaker. Silipa is yet to connect. Kara is trying to help her, but please be patient with us. Thank you.
At the moment, Silipa has already emailed Dr. Tan and Dr. Michael Burling her slides. Just in the meantime, while I still try and get her in. Silipa's in Perth in Australia, and she's having a few issues connecting in everyone, but I'm not sure. Aileen, you might want to talk about the last meeting that you had in the Pacific about cervical cancer. I'm not sure in the meantime.
Why don't I open with a word of prayer and then we'll go from there.
Sounds good.
Okay, let's open word of prayer.
That would be good.
Whaftai le tuar mātou tama e lo lofa malawanga lei, whaftai mo sui fua maua, whaftai mo le lo lofa malawanga lei, ai mātou uma mea e whaia i o mātou tangata, ai mese lo mātou le nei service o le Pacific Society Reproductive Health, whaftai mo mea umo e whaia, whaftai fui mo le panel for Dr. Ling, Michael and Silipa, and also Kara. Also, Lord, whaftai mo all the participants to atu nei session i atu o tama Father, we want to thank you and bless you, ask for your anointing, your blessing upon the speaker, also for the panel, and especially our participants. Father, we ask for your blessing, Lord, for helping us, Lord God, to get on top of cervical cancer. And yes, we can do it, and as a team, but also rely mostly on you, our Heavenly Father, to help us on how to do it properly. In Jesus' mighty name we pray. Everybody says, Amen.
Thank you, Robert.
Thank you, Rupeti, for that. My name's Ling Tang. I might just say a few words. And today's topic that we're going to discuss is, can we eliminate cervical cancer in the Pacific? And if so, how can we do it? And the speaker today that we have is Dr. Silipa Naiqiso. Unfortunately, Silipa is having some issues with trying to join us. But in the meantime, I am going to introduce our panelist in obviously Dr. Michael Burling, who did the excellent talk a couple of weeks ago, is one of the gynae oncologists at Westmead, and Michael's from Tonga in New Zealand and Australia, so he's very cosmopolitan. And if we can't get Silipa on, then we might have to get Mike to actually help us with some of the slides. We've also got Dr. Kara Okesene, who we all know that needs no introduction, and I'm just going to briefly introduce Dr. Silipa Naiqiso. So when she comes on, we can just get on with the talk rather than having to wait for that. Silipa is a gynecological oncology fellow at the King Edward Memorial Hospital in Perth. She is a second-year trainee, and she's training to be a subspecialist. We're very proud of Silipa and what she's achieved, and the fact that she's followed her dreams to train to be in New Zealand as a gynae oncologist, and hopefully we'll have some collaboration with her colleagues from the Pacific. And so today, Silipa's topic will be, can we eliminate cervical cancer in the Pacific? This is the second part, and we'll be really talking about secondary prevention. So that's the aim of the talk today, and hopefully we can get Silipa on the line. In the meantime, while we waiting, if the participants would like to converse and chat with us and maybe send us some messages, and Mike and I can maybe help with having a discussion. If there's anything you'd like to discuss, it's a bit the other way around in terms of doing this, but at least hopefully it's a good time for us to maybe have an informal chat while we're waiting for Silipa to come on. Any comments, Mike? We might as well just make this an informal session for something while we're waiting, rather than sitting here waiting, for Silipa.
Well, yeah, I'm happy to agree with Aileen. We can actually just, if people online have any questions, we can sort of informally discuss it. I think we were planning to send out a questionnaire to all the islands about what is currently happening in each of the islands. As the last time we sort of had any kind of information, which was very which we collected was back in 2019, and it would be really good to know exactly what is actually happening in all the islands as part of something we were, Dr. Tan and I both quite interested in sort of looking at the progress of the approach to screening, what's happening with HPV vaccination in each of the islands. As it would be good to sort of think about writing an article for the New Zealand Australian Journal of ONG, but also to PSRH journal, and just updating the whole Pacific and what we're doing currently and what's the current aim in the what's the current plan forward for all of the islands, and how we can all work together to have a more cohesive and plan to try and eliminate cervical cancer, especially with the WHO goals. I can see that people are starting to put some questions in there.
We're just saying hello, Mike. While you're talking.
Very good. I'm trying to find if Silipa sent me her talk, and then we
I
can.
think she sent a talk, but she's just sent the slides now. So I think that if I have got a copy of slides, have you got that?
She's not included me in that email.
She has.
Is
Your
it
name's on
gone
it.
to my Hotmail account?
Yes.
Just let me pull it across.
Yes.
You might be able to screen share your one, Aileen, and then Mike can probably talk to it.
Right. I just need to get it on first, so bear with me.
Sorry, everyone. I think there are issues connecting from Perth. Maybe because Perth is so far away from
It's not that far away, but
Silipa. The other alternative
the other
is
side of the.
oh,
I'll just pull it up, Aileen, on my computer here.
Just answer some questions while you guys are doing that.
It's just saying hello. Is that coming up, Aileen, the
Yes.
shared screen?
yeah. So the slides are coming up.
Yep. So what we might do is, Mike, do you mind saying a few words? I need to apologize to everybody. We can't get Silipa. She's the speaker, but otherwise we'll be wasting our time. So maybe we can start doing that. Mike, would you mind?
No, absolutely not.
And then we can just chat around it until she can come on, or otherwise we'll just use that.
Okay, so do you want me just to start, Aileen?
Yeah, I think we should start, because otherwise everybody is waiting, and then when she comes on we can talk. But that would be really good if you could.
Okay.
So everyone, we are just going to have to use some Silipa slides, and Michael's going to share. We've had a look at it very previously, but she's updated it. So bear with us. Michael will do his best, as he always does. And so I'm going to introduce Mike again. And I know that everybody knows Mike, but Dr. Michael Burling is a gynecological oncologist from Westmead in Sydney. We're very proud of Mike and what he's done. He's an amazing doctor, an amazing person, and very positive and very passionate about the Pacific. Obviously, it does help that he's part Tongan, though the other part is Australian. So no worry. And Mike will between Mike and I will try to do the secondary prevention of cervical cancer in the Pacific. And so we'll start.
Okay, thank you, Ellen, again. So I thought becoming a boss was an easy thing. Well, not an easy thing, but I decided to, after having a baby about 6 weeks ago, I thought I'll delegate. That's what apparently bosses do these days, is to delegate the talk to Silipa. So I asked Silipa as a fellow to present this and do this talk for me. Silipa's PGN, Silipa and I went to university in Auckland. We're very good friends. She's a great colleague, and she's done an amazing job here. So I'm gonna slightly apologize. I'm gonna do this on the go. But as you remember, I presented, the first talk was just on primary prevention on HPV vaccination, and that does have a pretty much probably our best chance of beating cervical cancer in the Pacific. But you know, this is most certainly something we can't forget about the women that can't have the HPV vaccination, is secondary prevention, and this is this part of this talk. This was from the Director General of WHO that look at cost-effective evidence-based intervention, including the HPV vaccination of girls, screening and treatment of precancerous lesions, and improving access to diagnosis and treatment of invasive cancer. This is most certainly the way forward to eliminating cervical cancer, as it is a public health problem, and this is most certainly a problem of the poorer countries. The WHO, as you know, that put forward a strategy about eliminating cervical cancer, but it also had a whole host of other targets there, and that's set out between 2016 and 2030. There's, as you can see, there are things like gender equality, reducing inequities, but one of the big things that was most certainly looking forward to was trying to approach and eliminate cervical cancer as a global issue. The Cervical Cancer Prevention Group came together in the Pacific back in 2019. This, I
can't, your slides are not moving.
It isn't moving?
Yeah, I'm sorry, I'm just stuck at the first slide. I don't know whether it's just me or whether the participants have the same problem. Can we just get some feedback from the participants to see whether they can see your slides? Because I've only got the head.
Sorry there.
That's better. Thank you. Sorry.
Is it going? Is it still moving forward, Ling? Okay. So this is the Cervical Cancer Prevention Group came together in 2019, and I presented some of this, and this was an important part of the way forward, because these are made out of leaders of the Pacific, and the delegates from New Zealand and Australia. The UN met to discuss the initiative to eliminate cervical cancer in the Pacific, and they discussed the WHO target of 90-70-90, with 90% of young women getting fully vaccinated, 70% of women getting screened with high performance tests, including either PCR-based HPV tests, and 90% of women identified with cervical disease receiving some treatment. It was agreed that any approach should involve vaccination against HPV, screening for and treatment of pre-malignant conditions, but also treatment of established cervical cancer should not be forgotten. Some modification of the WHO draft guidance, a guideline was felt appropriate to enable smaller nations to screen multi-age cohorts, and that's sort of a part of this working group's recommendations. This sort of came about, and as you can see there was the targets on that we were committed to raising awareness in the Pacific about cervical cancer, and there was the vaccination approach that we talked about on the previous talk, but also the main thing here was the screening, urging Pacific Island governments to transition to some kind of delivering of an effective cervical screening, HPV testing, and precancerous treatment, and consideration of some self-collection of vaginal samples, or in order to facilitate scaling up or acceptability in the Pacific. There was also discussion around treatment and not forgetting that these also come with an important focus on the workforce and and establishing a registry so we can actually for quality control and actually allow us to be able to do research and audits to how we can actually improve these services.
Sorry to disturb your mic, but Silipa says she can't control the slides, but she can actually talk now.
Oh, very good.
Okay, here she is. Hey Silipa, how are you going? Okay, so how are you going to be able to manage? Do you want Mike to manage the slides for you? Can everybody still see the slides? Silipa?
Can everyone still see the slides at the moment, Aileen? You can still see it on the screen?
Yeah, the slides are visible.
Yeah. Can you
I've
hear
lost Silipa
Silipa?
again. We've lost her again.
Silipa, can you hear us?
Okay, they can see the slides and the notes as well, Mike.
Oh, really?
So maybe we should just deal with that, and if we can, it might be the slideshow. I don't know, and then we might have to continue because I don't know where Silipa's gone to again.
Okay.
Michael, I think you need to go on slideshow.
You need to go on slideshow.
On a full screen.
Let me just.
Yeah, on the top there's slideshow.
Just this.
Yeah.
So when I click on this one, can you guys see the slideshow only, or are you seeing the?
No, we're seeing the notes, we're seeing everything. So if you just say maybe play from current slide, and then that should help. Silipa, how are you? You're going to be on. Silipa, are you on?
You can, I can hear you. I can see you as well. I can't see the slides from
Okay,
here.
no, we're
I'm so
just having
sorry.
Mike's just reorganizing that at the moment. So are you going to be stable? Because you were there for 2 minutes and then you're gone again. Are you okay?
We can't hear you, Silipa, unfortunately.
Can't hear her. So can I suggest maybe, Michael, we do the slides and we carry on, because otherwise this is a bit inconsistent. So let's just do that. Sorry.
Are you still sorry there, Aileen. I don't know if I'm sharing at the moment at all.
No, you're not. We're just seeing you at the moment.
Can you see that,
Yes.
Aileen?
Yeah. So I think start from maybe the slideshow, and then just.
Every time it goes to my slideshow, though, it shows the presenter view for some reason. I'm not sure why.
Just go down the bottom, Mike.
That one there.
Click on that.
See, it's showing you guys the notes and everything.
No, just the first slide at the moment.
Okay, how about that?
It's just the first slide as well.
Is it moving?
It is, but we're seeing the notes as well.
Yeah, so that's the only thing is my computer is just it won't show anything but that that view, unfortunately.
Okay.
Let me see if I can. Is that better?
Yeah, that's better. That's the one.
Okay, sorry.
That's a correct one.
Okay, that's perfect. So
This is
well
what
done, Mike.
we have
And
to-
I think we'll just get Mike to carry on if that's all right. Thank you for doing this because I
No,
think
that's okay.
sometimes it's very unreliable.
um, I'll just move on to the next slide. So in terms of cervical cancer prevention, the most cost-effective way of preventing cervical cancer is primary prevention, and we've spoken about that already. And however, only a couple of Pacific countries have incorporated this into their periods of time due to costs, and therefore having a robust sort of secondary prevention program is the next step. And this is what the talk about is going to be about today. So as we already spoken about, the burden of disease in the Pacific ranges from about 10 to 30 per 100,000 women of cervical cancer that affect women in the Pacific. There is no good screening program out there due to financial costs, infrastructure, geographical challenges that, and therefore the screening in the Pacific at the moment is purely sort of opportunistic. There are a few countries that have some sort of screening program, but it's really limited. So what we want to talk about today is sort of the principles for screening in the low resource setting. What age should we start the screening at, or what age should we be screening at? The types of secondary prevention strategies that we have some kind of evidence that it works at, and you know the Pacific experience in these areas, and we'll just go through that with the talk today. This slide was courtesy of Dr. Tan that looks at the snapshot of cancer services in the Pacific just before COVID happened. As you can see, Fiji has a cancer service that can do surgery, and chemo and radiation has been is sent out to India. We have opportunistic screening program and has a nurse-led palliative care service out of Suva. A few other countries have surgical services like Vanuatu, Tonga, and Kiribati, but no access to chemo radiation, and a lot of places are just having opportunistic screening. Tuvalu has no stats at the moment in terms of pap smears, and has issues with lab issues and no palliative care service there. Kiribati, the same thing, no vaccination, no cervical screening program. Vanuatu has a screening program that was using the group out of Queensland to run this, where they're doing cytology and HPV testing, and they were using a lot of funding from the Ian Fraser Foundation, but they again don't have a palliative care service and no real support for that screening program. But I think they're coming into one of the other fellows that I work with, Dr. Emma Allenson, and the Ian Fraser Foundation want to run a pilot program out of there to improve their screening and treating facilities. Samoa has about 12.6 per 100,000 women, 10 new cases per year, and 6 cancer deaths in terms of, and it's the second leading cause of death in women in Samoa. So still, you know, quite a bit of burden there. So principles of cervical screening programs in low resource settings, that we perform them in primary healthcare. They're usually performed by nurses or healthcare assistants or workers. It really requires little technology or staff training to perform it, process it, and interpret it. And I know that I think about a year or two ago, the Chinese wrote a paper in one of the journals about the importance of immediate results and having results within a day or a few hours, improving compliance with treatment in their population. Screening age is an important one, and obviously, screening between the age of 30 to 39 has the greatest impact in preventing cervical cancer and death from it. One of the Indian randomized controlled trials of about 80,000 patients between the age of 30 to 59 assigned to VIA with 4% acetic acid or cervical cancer health and cervical health education. This allowed them to have a colp biopsy and cryo excision, and at the 7-year follow-up of that population, there was a significant reduction in cervical cancer incidence and death from cervical cancer. And when you looked at it, the greatest impact was when in the age group of 30 to 39, which there was a 38% reduction, where if you went to the 40 to 49 or the 50 to 59 group, the reduction was only about 18 to 24%. And again, there was up to a 66% reduction in mortality in cervical cancer deaths when you screen at the age of 30 to 39. So quite a significant impact there. So, secondary prevention for cervical cancer is sort of based out of national cervical screening programs, and that's there are 4 main types of these programs. So one is the national screening programs, that's basically similar to what programs we have here in Australia and New Zealand. Some use what is called visual inspection with acetic acid. There is point of care HPV testing, or a combination of screening tools. And obviously there's a screen and treat protocol for some of these. With all of these screening and diagnostic tests, there is inevitable the trade-off between sensitivity and specificity, and where specificity can be improved with the reduction of sensitivity can be tolerated. So you either overtreat or undertreat in those sort of cases. So in terms of national screening program, and as I said, Australia and New Zealand has most certainly are the 2 countries that sort of have very strong screening programs, and this is very clearly demonstrated on this graph here, that since the New Zealand was the first country in 1990, Australia became then adopted in 1991, and you can see that there's been a significant reduction in both cases and mortality. So they most certainly work, but they are very, very expensive to run and require a lot of resources to run these programs. Obviously, as the WHO has principles for population screening, and cervical cancer ticks all of these boxes about why it's that cervical cancer is most certainly a preventable cancer, and we can screen for it because we understand it, we know the natural history, there is an acceptable treatment and suitable test. And all of those listed there are certainly things that we can, that cervical cancer screening falls into. But, as these most certainly, there's a rate limiting factors in the Pacific, and that comes down to significant infrastructure, the personnel to run the screening programs, the cost, but also the database that required to, again, maintain a quality assurance to these screening programs. And we know from Australia and New Zealand that how important quality assurance is. In terms of expenditure in the Pacific in health expenditure, one of the challenges is the costs and the health expenditure. So in terms of Pacific budgets, we spend about 2 to 5% of our GDP, where Australia and New Zealand spend about close to 10% of their GDP on implementing on health. So when implementing screening programs, there's a major factor there. In the US, it is about $200 for versus $4,000 to $5,000. The health expenditure in most of these countries are much bigger than it is in terms of Australia and New Zealand. And also, you note that the external health funding from Australia and New Zealand is zero. I think in Fiji, they depend on about 10% for their funding for their healthcare. Samoa is about 53%, and Tonga depend on up to 80% of their healthcare is from funding from external funding. The other consideration is the availability of the specialist workforce, and Dr. Ekaroma published this in 2019, showing the current workforce capacity in the Pacific. In this study of showing.
No, don't. Ignore. Sorry.
The number of ONG specialists throughout the region, and you can see that significantly is and not very many of us around the Pacific to maintain that sort of care. And the other challenges here, and I think this came back to issues that Fiji had as well as other countries, the resources to process cytology, led to Fiji having a bottleneck problem of about 20,000 slides per year in Fiji, and that was very difficult to maintain. The other country that does a lot of cytology is Vanuatu, and they take their turnaround time for cytology is about 3 months, because it's sent to Australia for evaluation and then goes back to them. So again, very expensive. The infrastructure required after cytology is colposcopy, and then again, colposcopy needs colposcopists, or people that are trained to do it and be able to perform treatments from there. So we go back to the next sort of screening program idea was visual inspection method using whether it's using acetic acid or iodine, Lugol's iodine. And this has been multiple papers looking at this. I mean, studies that say it does reduce overall incident and mortalities. Quite a lot of data come out of India. Again, I talked about that before, but there was also other trials from South America and Africa looking at a visual inspection. And the problem with it is that in low resource setting, it's been found to have cancer detection range of up to about 1 to 10 per 1,000 women. But there were still issues around visual inspection. The sensitivity and specificity, if you were looking at the data, suggests that it's sitting between 80% to a specificity up to about 85%. There are two forms of this method. One is using acetic acid, as I said earlier on, and the other is using Lugol's iodine. This, again, the data suggesting there was a meta-analysis of about 11 studies, which included about over 58,000 women in India and Africa, and that still the sensitivity and specificity remained the same. What they found as well was that there was challenges with when women had STIs, so things like trichomonas, chlamydia, and gonorrhea made did not alter their specificity and VIA in that cohort of people. But and the other thing that they did look at was VIA with magnification, and that was another meta-analysis that showed three papers or 3 trials looking at this. And if you looked at the ability to detect CIN2 or more was around 87%. So there's some data there to support that sort of the use of VIA. So the advantage of it is economical. It requires very little equipment, and can provide, you can train healthcare assistant to perform it, and that was based out of the data out of Africa. The challenge is it's low positive predictive value. Therefore, it's sort of, if abnormal, you still need to perform a biopsy, and you're likely to lead to more over treatment than under treatment. When we looked at the Pacific experience with VIA, it was felt that it was effective alternative. However, it was associated with HPV-16, but not other high-risk HPV. And this paper, they looked at just over 1,900 women with between the age of 30 to 49, and they performed most of their treatment as an outpatient and using cryo in this paper. And 91 were referred to outpatients, and two diagnoses of cervical cancer, and about 8 patients had CIN2 and 3. So again, this was sort of just early experience. But, and the next sort of screening modality was the high-risk HPV testing, or point of care testing of high-risk HPV. And I think this is probably where the world is heading towards for low middle income countries. The HPV testing on cervical cancer incidence and mortality shows that it can decrease HPV as a testing as a part of screening has been reduced mortality incidence, and is now used in Australia for cervical screening, and has a high sensitivity and specificity compared to cytology alone. This study was based out of rural India in 2009, and this was compared to cytology or VIA, and HPV testing showed a reduction of up to 50% reduction in stage greater than or equal to stage 2 cervical cancer. And you can see at the bottom here, the HPV line is the orange line at the bottom, and it showed clearly it was 50% reduction in the incidence of stage 2 or higher cervical cancer and mortality. And that was comparing to the other, to VIA, cytology, or control. So quite convincing evidence there. The specificity and sensitivity, as I said too, is very high. It's over 90% or close to 90% with specificity. However, laboratory-based HPV testing is currently what is used in Australia, and it is expensive and not feasible for low resource countries. So, however, PCR-based sort of rapid HPV testing, which takes about 35 minutes, can be used, and it takes up to the 14 high-risk HPV types that can also be used with the same equipment that implements TB or HIV testing, which is portable. The other important aspect of this HPV test is that it can be self-collected. So there's good data and meta-analysis showing comparing self-collected and versus clinician-collected high-risk HPV testing showed that there was basically the same. So this was a Dutch study showing that when the patient did it just self-collecting versus the clinician, the patient actually did better. It was 98% versus 89% with the clinician. And actually that data has been consistent even when you look at when you teach women to do self-collecting for STD testing, that women, when they're self-collecting, follow the instructions very closely, where doctors generally just have a quick look. They usually wipe fairly quickly, and hence why the doctors pickup rates are a little bit lower, but it was not statistically significant. So this test, so the HPV self-testing was the Dutch trial there. And you can see here that this rapid HPV testing only takes 35 minutes. It's the newer one that people are having great interest in. So what are the advantages of HPV? It's highly sensitive and specific. I don't know if that was supposed to be lower or specific, but it's supposed to be higher specificity. There's a point of care testing. So, you know, people have the option of doing self-sampling, which I think in a lot of Pacific Islands, and we've seen this data coming out of New Zealand as recently, showing that women, Maori women, were more comfortable doing self-collection. And there's a move in Australia to actually have all of the screening done with self-collections at home, and then only if you have high-risk HPV to call women in for a test. The equipment is just battery operated. It allows us to screen and treat if you're doing it within fairly quickly turnaround. And there is still a risk of overtreatment, but it's most certainly much lower than VIA. That there are challenges we in terms of follow-up and the continual follow-up of high-risk HPV positive women are something that we need to look at a strategy to look at as well. When we combine testing, there's good data that it works and therefore it probably slightly reduces the number of overtreatment. And this was based out of a paper out of South Africa with just over 12,000 women, where they were doing both. And that showed that, you were treating less overtreating, but you were picking up more women with a CIN2. They've actually done also a study looking at this in Papua New Guinea, where 92% of women with high-grade disease were appropriately identified, compared to 47% just using VIA. So you can see that, most certainly less false positive rates and with the combination testing and point of care HPV. Screen and treat, again, that's using both high-risk HPV testing, VIA, and then treating if you think that was appropriate. It has been shown to be safe. Dr. Denny, who's one of the leading professors out of South Africa, has basically dedicated a lot of her life to sort of looking at this see and treat approach, and has been instrumental in writing and helping the WHO with writing a lot of its guidelines. So she showed a randomized control trial of just over 6,500 women between the age of 35 and 65, where they did screen using HPV testing and then VIA, and then subsequently randomized them to one of three groups. So one, they use cryotherapy if you had just positive high-risk HPV DNA, cryotherapy if you had a positive VIA test, or delayed evaluation. And over 36 months, they showed that the cumulative rate of CIN2 positive detection continued to be lower in the VIA and treatment group of 3.8%. The HPV group was 1.5%, and the delayed group was 5.6%. And what they showed was that the results showed concluded that both screen and treat approaches were safe, and it resulted in a lower prevalence of high-grade cervical cancer precursor lesions compared to delayed evaluation of 6 to 12 months, with some of the countries that have national screening programs generally go down that route. So this is sort of a flow chart of what the WHO sort of guideline looked at in terms of, so women were screened with positive high-risk HPV or VIA, and high-risk HPV followed by VIA. And then if you were eligible for ablative treatment, you either had thermal ablation or cryotherapy, or if you weren't eligible for these, that you would have a LEAP. And there are eligibility for these sort of treatments are listed in the WHO guidelines related to the type of transformation zone and things there. So I'll just show you. So in terms of cryotherapy or thermal ablation, is using one of these mobile solutions that where you can apply cryotherapy directly onto the cervix, or you can use thermal coagulation onto the cervix. When comparing thermal ablation to cryotherapy, there are very trivial differences in terms of benefits and harm of these two treatments. So systematic reviews of randomized or non-randomized controlled trial found little difference. And the proportion of women who are treated with thermal ablation was 91% and cryotherapy was 90%. So as you can see, there's very little difference there. Cryotherapy is easier, it's cheaper. There's no requirement for local anesthetic, but serious complications are less likely. And one of the major disadvantage of it is just the canisters for nitrous oxide, where thermal coagulation, you're just using heat to ablate the cervix. It does require an adequate depth of necrosis with it, and you probably need some local anesthetic if required. But there are some newer technology to use thermal ablation in this sort of field. In terms of specific experience with See and Treat, this group, I think, are based out of Australia, piloted a trial in Fiji in 2018, looking at aiming to screen women with for HPV infection and point of care testing, and that was based out of Western Fiji, and 5 of the at the smaller hospitals. They had 316 patients between the age of 30 to 50. And if you had a high-risk HPV detected, then they were offered a CULP and LEAP at the time of their review. And they ended up having 21 women with positive high-risk HPV, and they performed 12 LEAPs. However, issues of colposcopy and LEAPs need to be still, taken into account, because these were specialists trained in ONG to perform these LEAP treatments. The next group work is basis for screening model recommendation in the Pacific. So in PNG, so Professor Glenn Moeller and his team perform screen and treat HPV testing, and I think I've spoken about that before. And they were using thermal coagulation with a heat probe, and this showed that they had found that 92% of diagnostic accuracy with their with their HPV testing, versus the 47% with VIA only. So that was, I spoke about that earlier on, but when they were using the point of care testing followed by VIA, they had 42% who were treated, of women were treated appropriately. 58% of women were missed, or 4% without disease were treated. obviously this showed that there was higher diagnostic accuracy with lower percentage of women that were missed with this sort of approach, and this is shown on this table here. They felt that the 13% of women overtreated was acceptable. The same group have set up a pilot delivery model of point of care HPV testing and treating strategy. So women would self-collect with the same day, and their HPV testing was done on the same day. The HPV tests were, if your HPV was positive, then you would have a VIA, and that was used not for diagnostic, but for clinical triage, and then determine whether you'd be eligible for cryotherapy or thermocoagulation. This flow chart here allowed them to work out their treatment plans for women. In the 23rd of June of this year, Professor Vallely's group has been awarded $1.5 million in funding for HPV testing and treatment and elimination of cervical cancer in the rural remote of PNG, and that was to use again the same sort of approach here. So obviously this screen and treat approach has acceptable for women in the low middle income countries. There's significant time saving here, and it's most certainly important to take in clinic efficiency. We can cryotherapy and thermocoagulation can be used by non-clinicians. It is cost effective, so treatments ranges from about $2 to $30 with cryotherapy, but $2 with thermoablation. The challenges are still, there's still a small risk of overtreatment, but it's lower than VIA alone. So in summary, the secondary prevention methods in the Pacific that would be acceptable as screen and treat method, and would be the point of care testing and VIA for eligibility for ablation. This will fulfill the principles of screening that can facilitate in this resource limited setting. It can be performed in primary healthcare setting. We can train nurses or healthcare assistants to perform them. It requires little technology and staff training to perform, process, and interpret these tests. The immediate results or the results that's been available a few hours or a day or so later is certainly advantageous. To achieve this, we all need to work together to achieve other components of a successful screening program to eliminate cervical cancer in the Pacific. And obviously we need to look at political support, coordinate corporations to try and get funding to allow us to do this. This will most certainly allow equitable access to this screening for all women in the Pacific. We need to effectively mobilize our resources and training to allow this to happen. It most certainly is important that we do a health promotion and allow health systems to and encourage the health systems to strengthen around this. This is this most certainly will allow the Pacific nations to be able to work together to try and eliminate cervical cancer from the Pacific. So, as I said before, we do need the political support, the coordinated cooperation, effective resource mobilization, and the mobilizing of these resources will strengthen most health systems. And we've seen this with COVID, where, you know, mobilizing of healthcares, of people to be able to give vaccinations or perform big screening facilities, and people do listen, and therefore, but it does need a significant health promotion and explanation to the women that this is an important health problem that we need to all address. And I think that that's it.
Thanks, Mike. Thank you for taking up the challenge and doing a good
just winged it, by the way.
Always really hard to have someone else's slides, but there's a lesson about when you delegate, you need to make sure you're the person delegated can actually come to the party. But anyway, that's fine. That's really good. I just want to perhaps, and I quite like people to participate, either the participants or anybody, about what their thinking is. But for me, I think I like to summarize, and I think that for my take-home message, and please just tell me if I'm wrong, but I do think that the three major ones that we keep on harping on again and again are the talk that Mike talked a couple of weeks ago. So vaccination, I think WHO is still very much into the vaccination, looking at 2 doses, maybe even 1, probably 2 at the moment. And at the moment, the current thing is that the vaccination is still probably about $5. They're trying to get it down to less. In terms of if you've got Papua New Guinea and Vanuatu on board, I think that the Minderoof Trust is going to be supporting Papua New Guinea for vaccination and screening, and we can talk a bit about that. And I think the Fraser Foundation is supporting Vanuatu, so that's good. When we were there in December in Suva, we did have 4 countries that the UNICEF was going to support. Unfortunately, I believe that those countries haven't received it, so it might be something we need to look to. The other thing that I want to also talk about in terms of secondary prevention in today's talk is really about trying to do the same thing throughout the Pacific. I think that WHO's recommendation and WHO's thinking about it is that HRHPV is a high performance test. So that's what they prefer people to do, is to do a HRHPV testing. And certainly I think Professor Bilali's work is, for me, a game changer, because it's something that can be scaled up. And what we're looking at the moment, the problem with the testing with the HRHPV is that it's still about $9 US. So getting the equipment, which I think that the suppliers can do it at a good deal, but getting that and being able to use that equipment for other things. And I think that being able to use it for STIs, HIV, and TB is really valuable, because it's not a standalone just HPV thing. So that's important. The other comment to make about that is that the reason for thermoablation is because of the easy access of carrying the equipment, and also it's a lot cheaper. It's $2 compared to $30 with cold coagulation. So the recommendation for WHO is that that they actually recommend that we try and use thermoablation. But last but not least, and I think that Swaran's in the audience, and the really important thing is the communication and WHO's guidelines. And I don't know whether they're out. They're supposed to have it out like in the last month or so in their new guidelines, is that to make sure that we communicate with women, especially women who are about 29, 30, and even if you just do 1 screening, you're going to save lives. So I think that to be pragmatic in the Pacific, not just to think that we want the best of everything, we actually should be working together to see how we can work as a group, and the collaboration and having one voice always gets you a bit better in terms of geopolitical things. And really the bottom line is the geopolitical willingness and commitment to that. So that's all I've got to say. So Michael, do you have any comments? Or Silipa, if you can actually get her to talk.
Sorry. I think Peter Sykes just put up something there, which is, hi, Peter. Yes, I agree with you, Ailing. I think we do need to try and approach this as a whole, rather than sort of and we are continuing to learn over time, and as the group out of PNG and Vanuatu do more and more of these sort of pilot data coming out that will support us in terms of the approach that we, as you highlighted, that we should go for it. And even if we can screen women just once in their lifetime, makes an enormous difference. Obviously, some countries are aiming at, ideally 2, that makes a bigger difference. But we need to take small steps. We can't just jump to a every 3-year screening program, because that's just not feasible. And I totally agree with you, Ling, that we should try and approach, that the Pacific should try and approach the same, whether we look at buying things in bulk to make it cheaper, and having, but again, it's about trying to share data with each other so we know what's actually happening and what's working in each of the different countries, and adapting as we go. But yeah, I think this is the way forward to addressing such a huge issue in the Pacific.
Well, can I ask Peter's question? Because Professor Peter Sykes is in the participant, and I'm a bit sad that he's not a panelist, because otherwise we can ask him questions. So his comment,
Sorry.
issues of cost. Obviously, we've talked a bit about that false positive test, and I think that, and also incident cancer rates and difficulty with follow-up. I mean, follow-up is always a main issue. I think that if we can get someone once, it's, we might just have to accept that. So any comments, Mike, about false positive and incident cancer rates?
Yeah, it's a very good question. The false positive rate test of the test is, I'll just sort of, I was just on a meeting the other week with the group out of Vanuatu, where when they initially actually introduced HPV testing in Vanuatu, there was a difference between their HPV testing and their cytology, where their cytology was actually picking up more abnormalities than the high-risk HPV. And they don't know whether it was the testing itself or the cytology. So they've actually changed the type of HPV testing that they were using. So there was a lot of issues there. But the issues of difficulty with follow-up is enormous, and that was highlighted in the Vanuatu group. And actually they just wrote a paper in the last International Journal of Gynae Cancer on their experience. And again, the biggest issue was the turnaround time with their tests was 3 months, as I alluded to before. And a lot of the women that live in remote areas were, or a lot of women were just lost to follow-up. So they had abnormal results, but they couldn't track them down. So some of it was because of locations of where they lived outside of smaller islands. But actually the worst group of patients that was a little bit surprising to them was the people that lived in the cities, where there was well, in the islands, as you probably already know, people move around without telling anybody that they moved to another address, and there's no way of sort of finding people moving. And they had I think a loss to follow-up rate of nearly 70%. So it's a huge issue, and that's a difficult one to address, I guess. And more importantly, the Chinese paper actually showed that the women that were, so that was an interesting paper, that the women that were tested towards the end of the day, so if you were tested at the beginning of the day, you got your result fairly quickly, and then you got treated during the day. But if you got tested towards the last 2 hours of the day and your result came back the following day, that they had over a 50% loss to follow-up. So women just went, oh, bugger it, I'm not going to go back to the clinic the next day to get, my result or my testing. So they got, that shows you just how important that turnaround period of testing results are. So it's a really, really important way forward of how we can make it, the turnaround test. There's, some of the testing you can load up to 14 tests per women, and then you get 35 minutes to turn around and you get your results back. So, that would allow for better screening and, testing on the same time and less likely to lose women to follow up. And I think that that would be the way forward for a lot of the islands as well.
Yeah, I think that one of the things that I think that we actually underestimate is the actual value of the community and the women, and the fact that to have any of these things that is to be successful, you need to be at the grassroots and need to have the buy-in. So I think that in certain places where some of these programs have run, they've actually had people that go ahead and people who they trust that organize the time. So the women would come with their families. They would, the families and the husbands will be entertained. They will be doing all this, and then everything is done, and then they sort of leave. So I think that when they looked at not having this healthcare workers and people in the community doing that, the uptake might not be as good. So I think that the work that Soren's doing, and in terms of that, and various other groups are doing it, it's really important.
I think there's something on the chat too. Aileen, you might want to have a look at it. It was from Peter again.
Sorry, we've answered that with Mike. I asked Mike to answer that verbally. Well, that was the questions I asked Mike. It was from Peter Sykes' questions.
Yeah. He came back on the chat to you.
Okay. Oh, sorry, did I miss that?
So he's just mentioned on the chat that many women with high-risk HPV that will not have high-grade disease. Selection for treatment will need to vary by resource and screened population, and absolutely right. Yeah. I mean, that's very true. And in Fiji, they had an unsuspected cancer rate or was 2 to 3% missed cancer cases needed to be expected in the first round of screening.
Thank you. Sorry, I didn't see that. So do we have any more further questions, or are we good?
No, I don't think there's any further questions. Not that it's come up that I can see. Yeah.
All right. So in that case, I'd like to say thank you to everyone, to Michael for being a star of the show, to Silipa.
Silipa, I'm so sorry, I didn't do any
We'll just have to have a chat
justice
to her about that, and to the participants for putting up with us and putting up with the technical problems, and also to Peter Sykes for joining and contributing. Much appreciated, everyone. So thank you all for your time.
Yeah. Thank you, everybody. Thank you for joining, and thank you, panel, for, Okay. Will Bridget say anything else, or that's it? You can probably close it now.
That's it.
Yeah. Thank you. You can close it now.
Okay.